We all were awakened this morning with record unemployment numbers. Not unexpected during the time of national crisis that we are facing. But what you may not know is that while there were some...
When you look at Wayne County in Michigan and you look at Cook County in Chicago, so we have integrated all of our information to not only look at where the cases are today, but how they're moving, so we can alert FEMA to where we think the next potential hotspot is. All of the counties that I've mentioned, the hotspots are in urban areas or in the communities that serve that urban area. And I think that's something very important to remember as we move forward. Because of the innovations within our private sector, we continue to have these new platforms added for laboratory testing. And these become critical platforms for states that have very low rates and very low rates needed to test. Why is that important? Some of these machines have wells and plastic plates that in order to be effective, you have to put on about almost 96 samples. And others are made for 4 samples or 24 samples at a time. So what's critical for us to be able to do is to match the need to the county and state. And that's the role that we can provide advice on, because we get to see across the whole country and where those items are needed most. And so this is allowing us to adapt and adopt really allocation of tests or recommendations to state of what piece of equipment they may need. Of the 550,000 tests, you can do the math, but we're still running somewhere about 14% overall. That means 86% of the people with significant symptoms, because remember, you had to have a fever and symptoms to get tested at this point. So still 86% are negative. These are really important facts for the American people. I'm sure many of you saw the recent report out of the UK about them adjusting completely their needs. This is really quite important. If you remember, that was the report that said there would be 500,000 deaths in the UK and 2.2 million deaths in the United States. They've adjusted that number in the UK to 20,000. So 500,000 to 20,000. We're looking into this in great detail to understand that adjustment. I'm going to say something that's a little bit complicated, but I'm going to try to do it in a way that we can all understand it together. In the model, either you have to have a large group of people who are asymptomatic, who've never presented for any test, in order to have the kind of numbers that were predicted. To get to 60 million people infected, or 6 million people infected, you have to have a large group of asymptomatics, because in no country to date have we seen an attack rate over 1 in 1,000. So either we're only measuring the tip of the iceberg of the symptomatic cases, and underneath it are a large group of people. So we're working very hard to get that antibody test, because that's a good way to figure out who are all these people under here and do they exist. Or we have the transmission completely wrong. So these are the things we're looking at, because the predictions of the models don't match the reality on the ground in either China, South Korea, or Italy. We are about 5 times the size of Italy. So if we were Italy and you did all those divisions, Italy should have close to 400,000 deaths. They're not close to achieving that. So these are the kinds of things we're trying to understand. Models are models. We're adapting now to the reality. There's enough data now of the real experience with the coronavirus on the ground to really make these predictions much more sound. So when people start talking about 20% of a population getting infected, it's very scary. But we don't have data that matches that based on the experience. And then finally, the situation about ventilators. We were reassured in meeting with our colleagues in New York that there are still ICU beds remaining, and there's still significant over 1,000 or 2,000 ventilators that have not been utilized yet. Please, for the reassurance of people around the world, to wake up this morning and look at people talking about creating DNR situations, do not resuscitate situations, because I know many of you will look up my numbers. The only people who are over really 1 in 1,000 cases are people that have very small populations, like Monaco and Liechtenstein. So you will see a different number coming from when your population is really tiny. One case can put you over 1 to 1,000 or 2 to 1,000. Thank you.
Good. We'll do questions in a moment. Dr. Thompson.
Thank you, Mr. Vice President. I'm going to change the topic just a little bit because there was a questions that came up, and I've been asked about this on a couple of media. But as I mentioned to you, we went into a phase 1 trial, and I keep referring to one vaccine. There's more than one. There's a couple of handfuls of vaccines at different stages of development, but they're all following the same course. And the course is you first go into a phase 1 trial to see if it's safe, and you have very few people, 45 people within a certain age group, all healthy, none at really any great risk of getting infected. And the reason, and it's effective. If it's not effective, get it off the board and go to the next thing. If it is effective, get it out to the people that need it. So you're going to be hearing over the next month or more about different drugs that are going to go into these randomized controlled trials. And I feel confident knowing about what this virus is and what we can do with it, that we will have some sort of therapy that give at least a partial, if not a very good protection in preventing progression of disease. And we'll be back here talking about that a lot, I'm sure. Thank you.
Tony, you can take a question.
If I could just get back to what you're saying about this idea of risk in drug manufacture, are you saying that at some point in the phase 2 trials, that if you're seeing some form of efficacy, that you may try to convince a laboratory to spool up production at that point so that there's a reservoir?
Even before. When I go into phase 2, I'm going to find somebody that's going to make it. Well, partially the federal government, I think in some respects to de-risk it, but also investments by the companies. A lot of companies are not shy now about doing that. Usually when you do that at risk, John, you got to give some backup for them. And we've done that. We've put hundreds of millions of dollars into companies to try and make vaccines. I wouldn't hesitate to do that for a moment now.
Have you ever had a conversation about that? On the county issue, talk about having low risk, medium risk, and high risk counties, or for Dr. Burks. But there's no domestic travel restrictions. What's to prevent somebody from a high risk county going to a low risk county? Don't you risk creating a patchwork system, allowing more cases to slip through the cracks and the virus to spread in other areas of the country?
I think this is a very important concept, and it's why we've really worked on messaging to the American people about these 15 days to stop the spread. Because part of this will be the need to have highly responsible behavior between counties. And I think the American people can understand that they will understand where the virus is because we'll have the testing data and where it isn't, and make sure that they're taking appropriate precautions as they move in and out of spaces. I think this will be critical for our future as we work together to really understand where the virus is and where it isn't in real time.
Dr. Burks, let me just follow up on sort of your modeling. Everyone's talking about this Neil Ferguson study out of Imperial and how the modeling's changed. You last week said, or it was on Monday, that you talked about a serology test, something promising coming out of Singapore. Where are we on a serology test? The president said very quickly. And then is that what you need to do, some sort of community survey so you can get to some of these X and Z's so you can figure this all out?
So we're talking to CDC right now. They are extraordinary in outbreaks and contact tracing. So they are going to be the workforce behind any new strategy that looks at counties that need to completely move into containment and surveillance and contact tracing. But part of what they're looking at now is where are these antibody assays. To be clear, there is antibody assays available right now, but they're by ELISA. And what we're trying to do is not just do ELISAs, because they can use that now, but to be able to have point-of-care rapid diagnostics like we have with HIV, where you just get a drop of blood, you put it on a little cassette, and it tells you if you're positive or negative. So that's what companies are working on. Yes, correct. That's the IgG to measure. Now, remember, that's not going to be helpful in diagnosis. That's going to be helpful for us to know how many asymptomatic cases there are, or were.
How close are we to figuring out what the asymptomatic rates are? Because that seems to be the big question here on where we are on the iceberg.
It is a very big question. And so we have people, the FDA is working on that around the clock. They do have applications that are coming in. We put out a call for applications. I've been talking about it from this podium. If you have an IgG assay, rapid test, not an ELISA. I mean, you could do the ELISA today because the SARS the original SARS antigens react very well to the current COVID-19 antibodies that people have, but we're really working on that, both so that we could have therapeutics that could be plasma derived. So thank you. Yes, we're very much focused on that.
How soon will you be able to classify these counties? Because there's a lot of testing that has not been done yet.
Well, you know, there are states, and I just want to really recognize state and local health officials that behind all of this have continued to test and have continued to do surveillance. So we do have states that have been doing surveillance all along, who have been doing contact tracing all along. It never gets reported because it's not, you know, it's not that exciting that they've identified 10 cases. But there are states doing that and have been doing it throughout this entire outbreak, and that's why we have some confidence that that testing has been going on. We have to expand testing for surveillance. But this is that, we talked about it a little bit yesterday, the flu platform. So the flu platform is driven off of emergency rooms and hospitals reporting flu-like illness to their state and local governments. And that then will trigger the individuals to get tested. So we have a platform that states and local governments are completely used to. They're not used to doing it this late in the season. They'll do it usually through the end of March, but flu usually tails off a lot by April. So we're asking them to continue the activation of screening for flu-like illness. Now, that doesn't get to his question about where's the asymptomatics and how much of that. That helps us find cases and contact trace on systematic cases.
Different guidance for the places, the counties that don't have the data yet? Will there be different CDC guidelines?
So these are very early days of us trying to, what we're trying to do is to utilize a laser-focused approach rather than a generic horizontal approach. And I think in the 21st century, we should be able to get to that. Why am I confident that we can do that? Because we do that in sub-Saharan Africa right now for HIV. That's how we're stopping the epidemic there. So we've done it. We've done it in resource-limited settings. So I do believe we can transpose that approach here to the United States and be able to have, we have granular data down to a GPS coordinate of a site of a clinic and hospital. We think that same thing can be done in the United States.
Dr. Hurst, quick question on the would you suggest restrictions to states for something like that? Like if there is a high-risk county and the restaurants are open in a low-risk county, wouldn't your fear be that people in that high-risk county go over to the restaurants?
So these are dialogues that the federal government has to have with state and local governments, because state and local governments make those decisions, and that's what's been inspirational to me, of seeing how much the governors understand where they are in their epidemic and what they will need to do in the future. This is what we're trying to tailor. It requires us to have very clear data disaggregation at the county and state level, but I think you've been hearing from us, these outbreaks and clusters, we've been able to very well define to date. The one that was in King County, the one that is now in New York City, the one in New Orleans, the one in Wayne County. So, and we can see that spread throughout the region and those closely related counties. So this is what we're talking about, how to do surveillance, how to do contact tracing, and how to do each of these items to make sure that you prevent that spread.
What's your timeline, do you think? What's your timeline for implementing guidance like this?
Well, we have to get all of our data together. We owe it to the president. And we owe it to the president to be able to make that decision. So that's what we're working on right now, is getting that granularity.
All right, guys, last question.
I'll go to John for a second. I can speak to that, though. The president sent a letter to all the governors today indicating that, as every American recognizes, that the importance of 15 days to slow the spread, that we're approaching day 15. And what the president told the governors, that we're going to listen to the very best health experts in the world. We're going to examine that data very carefully, and we'll be presenting this weekend, the president, a range of recommendations and additional guidance for going forward. The president's made it clear that, in his words, he wants to open the country up, but we're going to do that responsibly And as the president told the governors today, we'll do that based on the data. John, one last one.
Mr. Vice President?
I'll go to John. We'll slip away.
Unless there was a last-minute glitch, we should probably see Phase 3 pass the House tomorrow.
Yes.
Already, there are many members who were talking about the need for a Phase 4. Do you see the need for a Phase 4? And if so, what do you think should be addressed in it?
Well, first, let me just say again how grateful the president and I know governors across the country are for the extraordinary bipartisan work that's been done on Capitol Hill. Not just in the bill that will be taken up by the House of Representatives tomorrow, but in legislation last week that extended paid family leave, free coronavirus testing to every American, made sure that all the agencies at every level of the federal government had the resources to meet this moment. It's really been a very inspiring time. But what the president's made clear to our governors, we're going to do whatever it takes. And already we're hearing from some governors about the need for additional resources. And we will evaluate those very carefully. And I think the Secretary of the Treasury has already indicated, and congressional leadership has already indicated a willingness to remain open to that. The American people know we're all in this together. And the unity that you see on Capitol Hill, the unity that this president has marshaled among governors all across this country in our states and territories will continue to drive forward. We're going to make sure the people on the front lines are our healthcare workers, the people that are serving them, make sure our state governments, make sure every agency of the federal government have everything we need to put the health of America first. We'll see you back here tomorrow. Thank you all.
Can I get some clarification?